Well, hello everyone. My name is Jamie Verhoeven and I'm a PhD candidate and neurology resident from the Netherlands. And with this very short presentation, I will give an overview of the research we have done on the association between stroke and cancer, especially in young adults. Currently, in around 10% of all stroke cases, the patient is affected is younger than 50 years old. And stroke in the young really clearly differs from stroke in the elderly, meaning that in up to 1/3 of stroke patients in the younger group, no clear cause of stroke is found. And as we know, an active cancer is a risk factor for thromboembolisms. And this association is most well known for deep venous thrombosis. It is even common clinical practice that when a patient has a deep venous thrombosis that is unexplained, we go and search for a possible underlying yet unknown cancer. So the association is much less clear at the moment for arterial stroke, though it could be reasoned that the same mechanisms apply for an arterial stroke as much as for a deep venous thrombosis. And so we wondered whether a cryptogenic stroke, mainly in young adults, could be a first manifestation of an underlying yet unknown cancer. With this study, we aim to investigate the risk of new cancer diagnosis after a first ever stroke. We wanted to stratify this for stroke subtypes, so separately for ischemic stroke as for intracerebral hemorrhage, different age groups, and also stratified for sex. And we wanted to compare this risk to peers from the general population. We performed a population-based observational cohort study using nationwide administrative databases between 1998 and 2018 in the Netherlands. And these codes were based on the International Classification of Disease. And we used for the reference data, so for the peers from the general population, we used the incidence data from the Netherlands Comprehensive Cancer Organization. With this approach, we ended up with a little over 27,000 young stroke patients, so aged 18 or 15 to 49 years old, and over 360,000 older stroke patients, so aged 50 years or older. In both groups, a little over 80% had an ischemic stroke, and the rest had an intracerebral hemorrhage. And in all subgroups, around 50% were women. In the younger group, the median age was closer to the upper age limit as could be expected at 45 years old. And in the older stroke group, the median age was 76 years old. On this slide, I've put two graphs. On the left, you can see the graph of ischemic stroke and on the right, intracerebral hemorrhage, and it shows the cumulative incidence of new cancer after stroke. And it has three lines. The blue line is the patient's age 50 years or older, the green line 40 to 49 years old, and the yellow line 15 to 39 years old, so the really young patients. And in these graphs, it's really clear that the cumulative incidence increases with age and also increases over time. Now, when we compare these incidences to the risk of cancer in peers from the general population, so matched by age and also sex, something interesting happens. Actually, the graphs both inverse. So the risk increase is actually much higher for the youngest patients compared to peers from the general population than for older patients. And also this risk increase is most evident in the first years after stroke and decreases over time. You can see in the graphs even that the risk increase after intracerebral hemorrhage is a little higher than after ischemic stroke. Though it has to be said that there were also less patients in the intracerebral hemorrhage group, therefore the confidence intervals are also much wider, making it a little bit harder to interpret. But the main difference we found between these two groups is that after intracerebral hemorrhage, the risk increase compared to the peers from the general population of having a hematological malignancy is much higher than after ischemic stroke. So what I would like you to remember from this presentation today is that young stroke patients are at increased risk of having a new cancer diagnosis in the years after stroke, mainly the first 1 to 2 years after their stroke, compared to their peers from the general population. And this risk was only marginally increased in older stroke patients and only in the first year after stroke. And we need to look further at pathophysiological mechanisms behind this association. And we should also try and find which of these young patients are most at risk, which patient characteristics belong to these groups. And then we should think about whether screening for an underlying malignancy should be or could be added to the diagnostic workup in young stroke patients. And if you want to know more, or if you want to discuss further, you can send me an email on the email address that is listed on the slide. Thank you for your attention.